So now we're going to talk about the examination of the lumbar spine. Similarly, you would use the same basic principles of look, feel, move. On inspection of the spine, the first thing you're doing is looking for the patient's balance to see whether they're balanced in both the coronal and the sagittal planes. In order to do this, the easiest thing to do is look at the shoulders, see if the shoulders are square, and then to use the pelvis to see if the pelvis is square. If there is a scoliosis, the spine would be twisted and one shoulder may drop. Similarly, looking from the side, I'm looking at Sarah's sagittal balance. If she had any evidence of a kyphosis, she would be bent forward, or if she had a hyperlordosis, she would be bent back. Continuing the inspection, it's always important to look and see whether there are any scars. These can be either in the midline, or to the side, or even at the front. Finally, it's important to look to see if there's any evidence of any spinal dysraphism which would indicate a developmental abnormality within the spine. If you were in particular worried about a scoliosis and there was a suspicion, then you can do the Adams forward bend test. In scoliosis, when the spine is rotated, the ribs tend to lift up on one side. Now that can be accentuated by bending forward. So if we ask Sarah to bend forward, what you would see is you would see that one side would lift up and the rib hump, as we call it, would become more prominent. Come forward for me. That's lovely. Next, we're going to feel. Look, feel, move. Again, before you put a hand on any patient, you have to ask them if they have any pain. Do you have any pain in your back, Sarah? Feeling down the spine, starting from the cervicothoracic junction, moving down the spine into the lumbar region. Any tenderness there?
No.
Good. So you can feel the spine. Okay. Next, for sensation, you would ordinarily test sensation in the legs because the lumbar plexus supplies the legs. But I think it's logical at this point to go to move. So what we're going to try and do is we're going to ask Sarah to move her lumbar spine. Now, there are different tests which are described, one of which is Schober's, which is where you take a region, if you just turn to that side, Sarah, for me, and you take the posterior superior iliac spines and you draw a line across them. You then draw a line 10 centimetres up from that. What you can then do is if I ask Sarah to move forward, you can see that my fingers are coming apart. Keep going, and you can see that my fingers are coming to over 5 centimetres apart, and that would be normal. Come up for me, and you can see they move back together again. A simpler way of doing that would be simply to ask Sarah to put her hands on the front. Just turn for the camera for me, put your hands to the front and slide your hands down the front. And again, you can document clearly where Sarah can move her hands to, whether it's mid-thigh, mid-knee, or in this case, down to her ankles. Come up for me. That's lovely. The next test you would do is for extension. Can you move yourself back for me? And that's lovely, and come forward. Now, in extension, you're loading the facet joints. So if patients have facet joint arthropathy or arthritis in the facet joints, that tends to be quite painful for them to do. Additionally, you might hear an extension catch, which is where the patient has a spondylolisthesis and the spine has slipped forward, and when you're bringing them up, it clicks back into place. You may even be able to feel that step when they're standing upright. Now, having performed the simple look, feel, move, as with the cervical spine, you need to go on to a full neurological examination of the lower limbs. It is my standard practice to perform my neurological examination with the patient sitting down. If you would like to sit down, please, Sarah, please. Now, again, with the neurological examination, the first thing we do is inspect. You're looking for any signs of obvious wasting or fasciculation, which would indicate a lower motor neuron lesion. Having done that, you could test for sensation. Again, like I said previously, you need to be able to know your dermatomes in the lower limbs. This is so that you can correlate, again, what the patient is telling you as to where the pain goes, what you're going to see on the MRI, so that if you're going to perform a surgical intervention, you have a good chance of giving the patient a good result. So if, for example, the patient had L5 nerve root compression, you would expect them to have pain in the L5 dermatome. This would be on the outside of the calf, radiating down the front of the foot and into the big toe. So going over the dermatomes, the L1 dermatome is classically in the groin. So this would be this region. The L2 is the top of the thigh. L3 is the top of the knees. L4 is the anterior shin. L5 is the outside of the calf, radiating forward and into the big toe. S1 is the outside of the foot, the heel of the foot, and up the back of the leg. Routinely, I would test those dermatomes using either a pinprick or light touch to ensure that sensation is normal. It's routine to ask the patient if they have any numbness, because they will be able to tell you, and that will again give you an idea of where the abnormality lies or whether they have any paresthesia. Do you have any pins and needles or any numb areas, Sarah?
No.
No. Okay, so having looked for wasting or fasciculation, having felt for sensation, you then need to see whether there is any abnormal tone within the leg. In this situation, what I tend to do is test for clonus. Making the leg loose and see whether there is any beats when you bring the foot up sharply. Next, having tested for tone, I then go to power. So I find that the easiest way is to place the joint in the position and then ask the patient to hold and maintain that position, and then the patient knows exactly what you're trying to do. Starting with hip flexion. Sarah, can I ask you to lift that knee and keep it there? Lovely. Bring that down. Bring the leg out. She's using her quadriceps now. I can feel her quadriceps. Keep the leg there, and I can feel the muscle tensing. Bring your foot up, tibialis anterior, you can see it, keep it there, and you can feel it. Drop your foot, bring the big toe up, keep it there. You can see the tendon of extensor hallucis longus. Good. Push down. Excellent. Moving to the other side again. Bring the knee up, keep it there. Good, relax. Bring the leg out, keep it there, relax. Bring the foot up, keep it there. Big toe up, push down. Good. When she's pushing down, you can see the gastrocnemius and soleus contracting. Do that again for me, Sarah. And you can see the muscle there. Having tested the muscles, at this point, if the patient has any evidence of root tension signs, it's logical at this point to see whether their straight leg raise is positive or not. Now, this can be done in a number of ways. You can either do it with the patient lying down, or you can do it with the patient sitting down. I often do it with the patient sitting down because they know what a straight leg raise is when they're lying down, but often they don't realise what I'm trying to do. So if it's positive in the sitting position, you know that it's definitely positive. If you bring your leg up for me, Sarah. Now that is the equivalent of a 90 degrees straight leg raise. If they had root tension signs, it would be positive. What you do is you bring the leg down again to take the tension off the nerve root and then extend at the ankle to bring the tension back on. And that is Leseg's test. And relax. Now, finally, having done tone, power, I would move on to reflexes. Starting with the knee jerk. Now you can see that Sarah's knee reflexes aren't particularly easy to get. So one of the things you can do is you can reinforce your reflexes, and that you do using Jendrasik's manoeuvre. And what I ask Sarah to do is put your hands together and pull when I say. Pull now, and you can see we've got a reflex. Relax. Pull now, and there we've got a reflex. Relax. Let's see if we can get her ankle jerks without. Now, here you're going to be striking the tendo Achilles. So what you have to do is you have to put the tendon on some tension, otherwise you won't get the reflex. And if you look at the foot, I've put the tendon on tension, and there was the reflex. We'll try that again, and there it went. Again to the other side, and there it went. While you're here, it makes sense to see whether there's any evidence of an upper motor neuron lesion, because I have a sharp point and I have a foot. So Babinski's test, the plantar response, is performed by passing the sharp point down the outside of the foot and bringing it medially to the ball of the foot. Are you ready, Sarah?
Yes.
And you watch the big toe and you see it goes down. Again, on this side, starting from the outside of the foot and moving round, and there it goes down. Similarly, if you're worried about the long tracts and you think there may be a cord lesion, seeing as you're in the region of the foot, it makes sense to test for joint position. So again, putting your hands on either side of the toe so that you're not creating any pressure on the top or the bottom of the toe to give the patient a clue, you can test for joint position sense. Now, telling the patient shut their eyes, shut your eyes, that is up and that is down. Moving back to the neutral, can you tell me which way I'm going?
Up. Down.
Good, so that's normal. And again, that's up, that is down. Tell me which way I'm going?
Up. Up.
Good, lovely. And again, what my usual practice is to test Romberg's again if I'm doing the lumbar spine independently. So stand up for me now, Sarah. Step forward, put your feet together and close your eyes. And again, you can see she's correcting herself through her afferent and efferent pathways. Open your eyes, that's fine. You can sit down. And that concludes the examination of the lumbar spine. Now, for sake of completeness, as I mentioned in the early examination, you can examine the lower limbs neurologically with the patient lying down. And we're going to show you how to do that now. Starting off with hip flexion. Sarah, could you bring your knee up for me and keep it there? Good. Kick the leg out, keep it there. Good. Bring the leg down, bring the ankle towards me, keep it there, and the big toe towards me. Big toe towards me, keep it there. Good. Push down. Excellent. Next leg, bring the knee up, keep it there. Kick the leg out. Push down. Bring the leg down, bring the ankle up, keep it there. Big toe up, keep it there. Push down. Similarly with the reflexes. Relax. When examining the tendo Achilles reflex, that can either be done, as I've shown you, by putting the tendon under tension and striking your hand. Did you see it go there? Similarly, there it went. Or you can strike the tendon directly by abducting the hip, bring the tendon into direct view, and striking it like that. Similarly, like that. Can you see that? And there it went. All right? Lovely. Also, whilst you're here, you can do the straight leg raise by bringing the leg up gently. Often the patient will be tender to the point at which they feel pain. When you've reached that point, you release the root and then reapply the tension by applying ankle extension. Release, and that would be a positive Lassex test. All right, that's lovely. Thank you.